Sydney, are those Christmas lights? Oh, your mic is broken. So McKenna, what's for dinner?
I'm muted, my bad. It's a quesadilla.
Oh, it's a quesadilla. Okay.
Sorry.
Good try.
Yeah, it's got chicken and cheese in it, I think. I don't know. It's all right. It's not the greatest.
Oh, okay. You make better quesadillas.
Yeah, definitely. Taco Bell, Boba. They have good ones too.
The Western schools already canceled school for tomorrow. And then my daughter texted me from Greenville. Greenville's already canceled classes for tomorrow. They'll be online tomorrow as well.
Hey, Dr. B, I can't hear you. I don't know if it's my computer or if it's not. I don't know, but I just thought I'd let you know.
No, I can't hear him either.
Now can you hear me? Testing, testing, testing. That worked. So, all right. Okay, there is a quiz on Facebook, and let me show you where it is. So you go to our Blackboard site and it's right here. And when you click on it, you will have to put in a password to begin. And the password, I'm going to give you the password right now. I will text it to you, so look at the text box. Okay, there's your password. Go ahead, put in the password and go ahead and take the quiz. Does anyone know where Bree is? Yeah, I don't see her in the Zoom class. Becca, it sounds like you're talking to a coffee cup. It's very hard to understand.
I think she said that she switched majors. Is that what you said?
Oh, no, that's Bree Mead. I mean, Bree Vilmont. I don't see her on the call in the Zoom meeting. Hope she's okay. Okay, let's see. All right, just about everybody's done. We're waiting for one person. Okay. All right. Okay, so you guys can see your answers. You should be able to see the answers. Can you see the answers? So go through the questions, figure out what went wrong, what went right, and essentially go from there. All right? All righty. If you have a question, use the chat function, or if I miss it and I'm talking and I don't notice it, just unmute yourself and ask a question. All I ask is that when you're listening, if you're not asking a question, please mute yourself. That way, my voice doesn't go through your speaker feedback into mine, and that will cause feedback, and that won't be fun for anybody. So we'll go ahead and get started. Did you guys get this handout I sent to you? Did you guys get that? All the handouts I gave you are on Blackboard under course basics. There's a shell entitled handouts, and those are all in there. So let's therefore go to okay, there we are. Let's back up to there. Oh, right there. Okay. All right. Let's go ahead and begin. So as we said before, there are genetic differences in cytochrome P450s, and they are affected by things like smoking. They can be affected by diet. People, for example, who eat lots of alkali-rich plants, they can have higher levels of certain cytochrome P450s. Milk thistle, as we said before, inhibits phase 2 reactions, and St. John's wort is a potent inducer of several different types of cytochrome P450s. And you'll see that on the handout that I gave you in a bit. Also, there are age and sex differences when it comes to cytochrome P450 activity. Males, on the average, metabolize drugs faster than females. Males have bigger livers. They have more enzyme per gram of liver. They will metabolize drugs faster than females usually. Elderly people, phase 1 reaction rates decrease, phase 2 reaction rates do not. So if you are working with an elderly population, it is beneficial to try to prescribe drugs that are predominantly metabolized by phase 2 reactions. The drug insert that you get with the medication will usually tell you that, or when in doubt, just ask your pharmacist. Drug metabolism in infants is not at all at first, and then their liver starts to come online, but there are some drugs that babies simply don't metabolize, and the drugs they do metabolize, they will tend to metabolize them slowly. The more adult ranges of drug metabolism don't really hit until they start to get about 8 years old in that range. Even then, there are some drugs they don't metabolize as well. So there are particular drugs you really don't want to use in babies if you can help it. Let's talk about these inhibitor-inducer interactions. So your handout should have a page like this. Please get that page out. This is going to be the basis of the case studies that we handed out last time. All right. And if you can't find that, this handout is on the web, is on the Blackboard site. So in this example, you have a substrate for cytochrome P453A4. And that substrate is erythromycin. Erythromycin is metabolized to an inactive metabolite. Now, grapefruit juice is an inhibitor of cytochrome P453A4. Therefore, if you take erythromycin and you drink grapefruit juice, you will not properly metabolize erythromycin, and erythromycin levels will increase in your body. And erythromycin is one of the macrolides that if it gets to too high a concentration in your body, it can cause cardiac arrhythmias. So grapefruit juice plus erythromycin, because grapefruit juice is an inhibitor of cytochrome P453A4, the predominant cytochrome P450 that metabolizes erythromycin. Combining those two leads to dose-related toxicity of erythromycin because you now have higher blood levels of the drug. Phenytoin, on the other hand, the anti-seizure medication phenytoin, is a potent inducer of cytochrome P453A4. So now you will get greater cytochrome P453A4 activity if you take phenytoin with erythromycin. Therefore, at normal doses, erythromycin, if you combine it with phenytoin, will get chewed up so fast by the induced cytochrome P453A4 that its concentration in the blood will never get to therapeutic levels and you'll have treatment failure. So that's one example of combining a drug with either an inhibitor or an inducer. The inhibitor causes drug-related toxicity, dose-related toxicity of erythromycin. The inducer, phenytoin, causes treatment failure because the drug is chewed up so fast. Now let's use the same inhibitor and inducer, but let's use a different drug that happens to have an active metabolite. So this is the antihypertensive medication, losartan. Losartan is metabolized by the cytochrome P450 2C9. Grapefruit juice is also an inhibitor of cytochrome P450 2C9. Without proper 2C9 activity, you will not convert losartan to its active metabolite. That will lower blood levels of its active metabolite and produce treatment failure. Blood pressure will not be lowered to the proper level. If, however, you combine losartan with phenytoin, which is an inducer of cytochrome P450 2C9, then you will create too much of that losartan active metabolite too quickly. Blood levels of that active metabolite will soar, and you'll have dose-related toxicity. You will correct the blood pressure too much, and you'll have hypotension. If your blood pressure is too low, now you run the risk of not properly perfusing your organs. Are those examples clear? Is there anything about those examples that are unclear?
Where are you getting, so I can see like on the page where you're getting the like grapefruit juice and the phenytoin, but where are you getting the actual like drugs like or azithromycin, like where are you finding those at?
You see the big arrow, the big clear arrow?
No, I printed it out, but I don't. Maybe mine looks different.
You don't have this sheet?
Is that a different paper?
It's the one,
Oh, okay. This one?
it's the one that the front page looks like this.
Okay, I was looking at the wrong one. That's my problem.
Okay, I'm on page 3 of the handout whose front page looks like this.
Okay, I found it.
That helps? Okay, now do you see it?
Yeah, I see it.
Okay, now does it make sense?
Yes, thank you.
All right. All right, well then, if you have it with you, let's take a look at the case studies we handed out. And I'll tell you what, I will do the very first case study for you. And then I'll have you guys break into groups, and then you guys can figure out these case studies on your own. I'll break you into little breakout groups, and then you can figure out these case studies on your own. Oh, this is a drug-drug interaction joke. So you guys know what Viagra, Propecia is a drug that prevents baldness if you apply it, well, if you take it orally. And so this is a little drug-drug interaction joke. So I thought that was funny. So maybe you guys don't think it's funny, but I thought it was funny. So anyway. All right, so case number 1, read it with me. The antifungal drug fluconazole was prescribed to a patient who was also taking the anti-epileptic drug phenytoin. One day later, the patient suffered from nausea, slurred speech, and a lack of motor coordination. So first off, azole antifungal drugs are notorious drug inhibitors. So the fluconazole is an inhibitor of cytochrome P450-2C9. Cytochrome P450-2C9 is very important for the metabolism of phenytoin. So because the fluconazole is inhibiting 2C9, phenytoin levels now rise significantly. And those side effects, you see there, nausea, slurred speech, incoordination, those are all side effects of excessive amounts of phenytoin. Those are signs of phenytoin toxicity. And from the case study on the ATI site, you remember that nystagmus, where the eyes all of a sudden move back and forth, that's another sign of phenytoin toxicity. So phenytoin will increase the levels of this anti-epileptic drug, thus causing the toxicity. Instead of prescribing fluconazole, some other antifungal drug that doesn't interfere with the metabolism of phenytoin should be used instead. Okay, so do you see how that works? If you take this handout here, you should be able to go through and figure out which particular drugs or substrates of which. So if you look at the 2C9 substrate, you'll see phenytoin is a substrate. You'll also notice that fluconazole is an inhibitor of 2C9. And since the patient is already on phenytoin, and since the fluconazole is being added to it, it's in all probability, the fluconazole is inhibiting something needed to metabolize the phenytoin. That's what's causing the toxicity. All right, are there any questions about that before I break you into these breakout groups? So let me count here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 13, 14, 15, 16, 17. We have 17 people. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Let's do 17 people. Let's do 8 breakout groups. I'll just have one of you in 3 breakout groups. So we have 2, 3, 4, 5, 6, 7, 8, 9. So let's see if we do the breakout groups. So we're going to do 8 breakout groups. They're going to be assigned automatically. And I will go ahead and I will visit your breakout group and tell you which one to do. Okay, so I'm going to create them. You're going to go to the breakout group, and then I will just enter and randomly. Okay, here we go. Oh yeah, you're invited to join the breakout groups. You go ahead and join them. Natalie, you're in room 1, so go ahead and join room 1. You guys are going to do case study number 2. Okay, room number 2. You guys are going to do case study number 3. All right?
Okay. Yeah.
Okay. Have at it. Yeah, room number 3. You guys are going to do number 4. Okay?
Okay.
Number 4. Okay? Good?
Got it.
All
What
right.
list?
Yep.
What list of like drugs were you holding up for us to like follow by? Was it on the back of our thing?
This one. This one should have all the information you need. The one that looks like this in the front. Okay? Because this will tell you.
I don't have that.
You don't have that?
Did you send that in the email?
I did.
I didn't
Okay.
print it
Also
off.
on Blackboard. It's called drug interaction tables.
Okay, I'll just have to
Thank you.
go back and forth. Okay.
All right. Room. Breakout. Right. Okay, breakout room. You got
hello?
case study number 5, okay?
5? Okay,
5. Have at it.
thanks.
Be proud, okay?
Okay.
Ciao. You guys got case study number 6. Case study number 6. Okay?
Thank you.
Has to do with birth control and that sort of thing. So if you do any women's health, this will be useful. Okay?
Awesome.
All right. I've got other rooms to visit. Ciao.
Bye.
Hi.
You guys are doing case number 7. All right?
Seven. Okay,
Okay.
thank you.
Okay?
Thank you.
Make
Mhm.
me proud. Okay?
Okay.
Okay. Come on, you. How do? You guys are doing case number 8, case study number 8, okay?
Okay.
Right. Make
Thank
me pr-
you.
Make me proud, all right?
All right.
All right, I'm gonna visit another room now. Very good, okay. Be the last one. Hey, gang.
Hello.
Okay, now case study number 9, we talked about that on Monday. Do you remember when I talked about lithium on Monday?
Yeah.
So that one's too easy for you guys. So do case study number 10, okay?
Okay.
Got it?
Yep.
Okay, make me proud, okay?
All right.
Kinetics is what the drug does to the body.
Yeah.
You
I
guys
don't-
heard that you're doing case study number 2, right?
No, we did not know that.
Oh, Natalie, I tried to tell you, but I think you were in the process of going to, okay. You're doing case study number 2.
Okay, thank you.
Case study number 2, okay? So carbamazepine is a notorious inducer. So if you look at, for example, at this handout here, if you just look, in fact, inducers down here, take a look at the 4th drug from the top. What do you see?
Vomiting,
Huh.
headache, dizziness.
Carbamazepine. Hey, hey, hey. Now, olanzapine. Is olanzapine a substrate of 3A4? It might be a substrate of 3A4, or it could be it's also, carbamazepine is also an inducer of 2C19. Yeah, so it's an inducer of 2 different drugs. So find out olanzapine is a substrate for which drug? Look that up. And I'll bet you'll find one essentially that might be induced by carbamazepine. Okay? Okay, give it a shot. Make me proud. I'm gonna undo the breakout rooms in probably 8-9 minutes. That enough time?
Yeah.
All right,
Thank-
guys. Make me proud. You guys have any questions? I'm just here to see if you guys need any.
No, I couldn't find the chemicals on the sheet, so I just went from the symptoms it was describing because I know the medications. And since he's not having any pain relief, the codeine is being inhibited, and then the fluoxetine is being induced because he's not being able to sleep, so or eating or moving. So there's influx of serotonin in the body.
So codeine, what kind of a drug is codeine?
It is a pain relief. It's
Does
a
it
pain
have to be
relief.
activated to work?
It doesn't tell us. It
Codeine's a
doesn't tell me whether
codeine-
it is activated through bioavailability or not.
Codeine is a prodrug. It's converted to morphine.
Okay.
So if you don't activate it, what happens to your pain relief?
Then it's not gonna, you're not gonna get any
Okay,
pain relief?
which enzyme activates codeine? Can you find that?
I didn't see codeine on the paper.
I read through the
Okay, let me give you a little hint. Opioids that are prodrugs in general are activated by cytochrome P450 2D6. And the other thing about 2D6, SSRIs are notorious 2D6 inhibitors. The worst one is paroxetine. but fluoxetine can also inhibit 2D6. So what does that tell you about codeine activation to morphine?
That it wasn't able to be transformed.
Sounds like somebody's on the right
Yeah.
track.
But we don't have any of the information to be able to come to that conclusion. That's kind of,
If you look up codeine online and ask what activates it, 2D6 will come up. I guarantee you.
yeah, it just wasn't on any of the sheets. That's where I'm.
Oh,
coming
yeah.
from.
Okay, so sue me.
I do
It's a substrate.
actually. now
Codeine is a
looking-
substrate for 2D6. That's what activates it.
Okay.
Okay?
Hmm.
That give you a good hint?
Yeah, I get it. I get the whole process.
Good, okay.
Once I have the information. It's just I couldn't find
Okay.
it.
By the way, these case studies, these are not made up. These are actual events when people didn't check for drug-drug interactions. This is the sort of thing that happens. So, and since sometimes people go to one doctor, they go to another doctor, and they don't necessarily tell the provider what they're on, who's left to check to detect the drug interactions? The nurse. So this ends up being actually pretty important for nursing. In fact, Clara, you were telling me about the places where you work. You probably have clients who are on lots of medicine.
Yeah, I work in the ICU, so
So this,
Yeah.
you're probably constantly having, because there are computer programs at some of these places, you can put the drug in and it'll flag any interactions.
mm-hmm.
You have to do that some,
Give it and the Pyxis, stuff like that. But
Yeah.
the pharmacy sends us up our medications and they do all that stuff, like the pharmacists themselves
okay,
will overview that stuff.
okay. Some people don't use pharmacists the way they should. You do. So.
Yeah, we do.
keep
They
using them,
stock
they're
all of our
pharmacists.
medications and everything.
Excellent.
And they also do our essays that we do on the amount concentrations of people and blood of the medications, and then they'll cater our next dose to the patient from what they've gotten from the lab.
Okay, good. Okay, I'm gonna go see if I can give other people hints.
Okay.
Hey, good job, guys. Good job, guys. You're on the right track.
Hello.
Oh, you guys are all done.
Yep.
Yes, and we
You
figured it out.
out?
We think so.
Okay. What do you think's going on?
So we had 5. We had case 5.
Okay.
And we said phenytoin, we believe. So she was given phenytoin to control seizures, but she also suffers from schizophrenia. So she's
Mhm.
given, how do you say that? How do you say that? Is it
Quetiapine?
thiopine?
Quetiapine, yeah.
So with the 2 drugs being taken at the same time, she basically started having schizophrenic, what is the word I'm looking for?
Symptoms?
Symptoms, thank you. So we were looking at phenytoin and quetiapine and said basically that phenytoin was a 2C9 inhibitor. And so it was inhibiting the treatment of the quetiapine. See, it was on page 4 of,
Yeah, I don't think quetiapine's a 2C9 substrate.
we couldn't find the like quetiapine on any of the substrates.
Quetiapine is a 3A4 substrate. And phenytoin is a potent inducer of 3A4.
So where is that on the?
Yeah, we just couldn't find it on the papers.
We couldn't find.
If you look that one up, you'll see the main enzyme that metabolizes quetiapine is 3A4. Basically, if it's not on there, you look it up essentially. And the main one is 3A4. Phenytoin induces 3A4. So essentially your quetiapine levels are going burp. So her psychosis comes back. I mean, those symptoms are pretty clearly psychosis, right?
Mm-hmm.
So phenytoin was induced, you said?
It's inducing 3A4, yeah.
Oh, okay.
Dr. Baratovich, I have a question.
Yeah.
So for case number 7, so the grapefruit juice is that the inhibitor then? Because it's like increasing the activity of like the
Carbamazepine.
of like the 3, because that one's the inhibitor of the 3A4, correct?
Yeah, so the carbamazepine is the one that was used before it went to generic. It was called Tegretol. Have you heard of Tegretol? It was a widely prescribed anti-epileptic. It's very effective, but it's got a lot of drug interactions. It's also used as a mood stabilizer in lower doses. So the grapefruit juice inhibits cytochrome P453A4.
Okay.
So carbamazepine levels then are going to significantly rise. And those symptoms, sedation, nausea, tremor, those are toxicity effects of carbamazepine.
Okay.
That makes sense?
Yes. Thank you.
You are most welcome. Okay, let's see who's. All right, so we still have. Okay. Okay.
I have a question really quick going back to case number 5. I just want to make sure I have it correct.
Sure.
So the phenytoin is a 3A4 inducer. So basically it's lowering the blood levels of the quetiapine,
Yeah,
which is making the treatment not work.
you have treatment failure. Yeah.
Thank you. I just
And
wanted to make sure.
in that case, since you have a patient who's schizophrenic and they're on an antipsychotic, but they have a psychotic break, that kind of reeks of treatment failure, doesn't it?
Mhm.
So it's probably the case that the drug being given for the schizophrenia is being degraded too fast. So you probably have an induction sort of case. And in that particular case, the phenytoin is a inducer, a big time inducer. Phenytoin is a very, very effective anti-epileptic. The issue with phenytoin is if you're on it too long, it starts to cause blood dyscrasias. So it's usually only used as a last resort. Okay. Okay, let me check on one of the rooms here, see how folks are faring. How you guys faring?
Okay. So, okay, I need a little clarification on it. So are we trying to, so we figured it out that the phenytoin is an inducer, right?
Yeah.
And then the ifosfamide is an inhibitor.
Well, the ifosfamide is the anti-cancer drug. So in this particular case study, I've got too many papers here. Case study. Oh, here it is. The ifosfamide is successful because the ifosfamide is a prodrug.
Oh, okay.
So the inducer actually increases the concentration of the ifosfamide. So that's why the increased level of the active form of ifosfamide, that this one was a hard one because anti-cancer drugs are weird. But the ifosfamide now is successful because you give him the inducer and now that takes the activity of the ifosfamide and it bumps it way up.
Yeah. And so it was, so the phenytoin still took care of the seizures, right? Is that what it's
Yeah.
saying? Okay.
This is a strategy that's called boosting, where
Okay.
you give something that either induces the enzyme that synthesizes a prodrug, or you inhibit the enzyme so that the drug you're giving has a higher has a longer half-life.
Oh, okay.
For example, this new COVID-19 drug that's out, this Paxlovid,
Mm-hmm.
it includes ritonavir, which is a booster.
Oh, okay.
And so boosting, that's also used for HIV medicines. Ritonavir is used in HIV medicines to boost them. That's a
Gotcha.
relatively common strategy. Does that make sense?
Yeah. So
Haley,
you're
you've got
saying
this
that the
Haley, you got this glassy
ifosfamide-
look on your face if to say, I don't get it.
No, I understand it. It's just a little bit confusing. But I think I'm getting it. I'm just
Okay,
kind of processing through it in the case study while you're
Okay.
explaining.
okay.
Did
Most
you-
people are back in the main room, so
I have a quick question,
yeah.
clarification. So
Go
you
ahead.
said that
Yeah.
the ifosfamide was acting as the booster?
No, the phenytoin in this case
Oh,
is
the
boosting
phenytoin.
the
Okay.
activity of the ifosfamide because the phenytoin induces it induces the cytochrome P450 that converts ifosfamide into its active metabolite.
Gotcha. Okay.
That's the boosting can either be you're inhibiting the enzyme so that the drug has a longer half-life that has more activity, or you increase the production of the active metabolite. Either way can be boosting.
Gotcha. All right. Thank you.
Thank you.
Welcome. Okay, is everybody back? Let's check the room. Oh, where's Claire and Sydney? All right, let me check on them.
So we would have to.
You good, gang? People are almost all back in the main room, so if you're done, visit us in the main.
Oh,
So we can.
oh, I
benefit-
thought you transferred us over.
Yeah, I was waiting.
You,
Oops.
you guys have to come back to the main room.
Oh, okay.
So,
Oh, okay. Sorry.
so I can, yeah, so leave, let's see here. I can close all rooms. Okay, they're given 60 seconds to leave the breakout room. Man, the power I have with this. Okay. It's the time of evening where we normally take our break. So why don't we go ahead and take our 5 minutes and then we'll come back, and the group that did case study number 2, you'll report first, and then we'll just go down 3, 4, 5, 6, 7, 8, and 10. So 5 minutes and then we'll be back, okay? Okay, let's go ahead and resume. I hope those case studies kind of gave you a flavor for why understanding how these work is important. There are computer programs you can use for drugs. If you have a patient, they have a drug, oh, I got this from another doctor, and you're unsure, there's programs that hospitals use, Pyxis and things like that. You can put it through, and so those are just examples of things. Many times drug-drug interactions are missed by the physicians, and it's left to the nurses really to pick them up. So something like this. Disease states can also affect the way drugs are metabolized. So some sort of liver dysfunction, liver cancer, hepatitis, alcoholic liver disease, non-alcoholic fatty liver disease, those can all affect the way drugs are metabolized. They can decrease the way drugs are metabolized. Cardiac disease decreases circulation of the drugs through the liver and through the kidneys. So that can affect both metabolism and drug elimination as well. Now, this particular cartoon, which is pretty silly, this is for those of you who like to drink coffee. This is to show you that sometimes increasing the metabolism with things like caffeine can also increase the rate at which certain drugs are metabolized. So that's also something to keep in mind as well. Acetaminophen is a bit of a strange bird. So because acetaminophen is so widely used, I threw this in here because acetaminophen, first of all, is primarily metabolized by phase 2 reactions. It is conjugated to a small peptide called glutathione. Now, whatever is not metabolized by phase 2 reactions is then metabolized by cytochrome P452E1. And it's metabolized to this metabolite with a forbidding chemical name, which is just called NAPQE. NAPQE, unfortunately, is quite toxic to cells. Now, if you make a really small amount of it, it's of little consequence and it'll usually be excreted. However, NAPQE is itself conjugated to glutathione, and that is a non-toxic metabolite, and then that is easily excreted. For that reason, making small amounts of the NAPQE is not a big deal. Now, if NAPQE accumulates in the liver, you're going to get substantial liver damage. And if you drink a good deal of alcohol, you can induce cytochrome P452E1. Induced cytochrome P452E1 increases the NAPQA production. That increases the potential for liver damage because eventually your glutathione reserves will be exhausted and now the NAPQA will start to damage the liver. This is a reason why many people who have hangovers and then take acetaminophen often end up with severely damaged livers because the binge drinking from the night before has induced cytochrome P452E1. Therefore, when you take acetaminophen to deal with the hangover, you now essentially make lots of the NAPQA that will damage your liver. An acetaminophen overdose of this type is a common cause of liver failure. In fact, it's 35% of all liver failure cases are either due to taking acetaminophen to treat a hangover or by taking too much acetaminophen. Does anybody know what the limit per day of acetaminophen should be? If you know, unmute yourself and just tell us. Okay, this number I want you to remember. Sorry?
Isn't it like you shouldn't take more than 12 in a day? Of like
12, 500 meg tablets.
yeah.
It's less
no,
than that.
It 200 milligram tablets.
So 4
Um,
grams.
4 grams. 4 grams a day is the limit. If you take more than 4 grams a day, you're cruising. Now, if you take 4 grams in one day and then don't take acetaminophen for several days, you're fine. But if you take 4 grams, exceed 4 grams a day and you do it routinely, you're setting yourself up for liver damage. So that's a number you should remember. And since acetaminophen is marketed as 500 milligram tablets, you should tell them no more than 8 tablets a day. And if they're combining that with other medications will tend to have acetaminophen in them. So Excedrin extra strength, for example, has acetaminophen in it. So those are things to be aware of as well. In the hospital, I believe many times acetaminophen comes in 300 milligram tablets, if I'm not mistaken. And sometimes for some sort of pre-op prep, you'll be asked to give the patient 300 milligram, 900 milligrams of acetaminophen, which is not an issue. So this is a very widely used pain reliever, but it has its caveats if you use too much of it because of the way it is processed in the liver. And people should never use it to deal with a hangover. That's the other thing that you should remember and educate people about when you are being a nurse, okay? So 4 grams a day, that's the limit. I'd like you to remember that number, all right?
How much different is ibuprofen from acetaminophen when it comes to like the toxicity?
Yeah, acetaminophen works in the brain and it works to decrease reception of pain reception in the brain. Acetaminophen, therefore, does not quell peripheral inflammation, whereas a drug like ibuprofen or aspirin or naproxen or meloxicam or Soldenac or whatever, those all do inhibit peripheral inflammation. Those NSAIDs have their own sets of side effects in the kidneys, in the heart, and also in the GI tract that we'll talk about when we get to NSAIDs. This one is an unusual bird because it doesn't have the GI effects, doesn't have the kidney effects, but it is hard on the liver. Whereas most NSAIDs are really not all that hard on the liver, but they're hard on other organs. Very good. Any more questions on drug interactions, biotransformation? There's much more we could say about it, but I think I've given you enough tools to be able to determine drug-drug interactions and understand them and what have you. Now, folks, keep in mind, these are pharmacokinetic drug-drug interactions. pharmacokinetic drug-drug interactions. If you have two drugs and they work on they work on the same pathway, but they work in two separate directions, that will be an example of a pharmacodynamic drug-drug interaction. Let me give you an example. So ropinirole is a drug that is used for Parkinson's disease. It's also used for restless leg syndrome. Ropinirole binds to dopamine receptors and activates them. A drug like olanzapine is an antipsychotic. Olanzapine inhibits dopamine receptors. And one of the side effects of olanzapine is restless leg syndrome. Whereas one of the potential side effects of ropinirole is psychosis. So you see how these two drugs kind of potentially antagonize each other from a pharmacodynamic perspective, because one activates dopamine receptors, the other inhibits them. That's a pharmacodynamic drug-drug interaction, ropinirole and olanzapine, or something like that. Okay, so before we go on to the other bits and pieces here, let's have you guys essentially report on the fruits of your labor in your little groups. So keep misplacing that. Oh, here it is. Okay, so those who had case study 2, go ahead and report essentially what you guys discovered, okay?
Okay, so we discovered that olanzapine is a substrate for carbamazepine on the substrate CYP1A2. And so by having the patient take olanzapine and carbamazepine, it was like too much. Brooke, you know what I'm trying to say. And so we recommend that the patient stop taking carbamazepine. And then I looked it up and it looks like you can take lamotrigine, maybe, is that how it's called? And that's a non-enzyme.
Lamotrigine.
Yes.
That's a good suggestion, to switch it to lamotrigine. The problem with lamotrigine is lamotrigine has to be stepped up. You step it up as you take it. And so you really don't get relief until you're up here. So you're going to need something in the meantime while you're stepping the patient up. But no, that's a good suggestion. Very good suggestion. That's a good job. Okay, so you have an induction of cytochrome P450 1A2, and that decreases the blood levels of olanzapine, since olanzapine is a substrate of 1A2. You increase those levels, you degrade the olanzapine, now you get psychotic symptoms. You have treatment failure, essentially. Very good. Okay. Case study number 3. I think
Can I
that
ask
was
a question about number 2?
Yeah, go ahead.
So I was trying to figure that one out during our break, and I said that olanzapine was a substrate of 2C19 and that carbamazepine induces 2C19.
I also see.
It's a minor substrate of 2C19. It's a major substrate of 1A2.
So how do you like tell the difference? Like if I were to be doing that case study.
You look
Like
it
how
up.
would I know? Okay.
You look it up.
Okay.
The pharmacist carries these books that'll tell you, or on the drug, the insert that comes with the drug, which you can look up online, it'll say.
Okay.
It'll say which enzymes. Some drugs are, they'll have like a major and a minor. Others, these two trade off. So if you inhibit one enzyme, doesn't matter. The other one just takes over. With that one, 1A2 is really the main enzyme.
Okay.
1A2 also is induced by smoking, by the way. So if your patient's a smoker, you're going to have to dose that drug up. All right, case study 3. I think that was Clara and Sydney. So Clara and Sydney, divulge to us your wisdom, please.
Sorry, I was trying to unmute myself. Okay, so Prozac is an inhibitor. It's a CYP2C9 substrate. So it inhibits hydrocodone and it inhibits the transformation of the hydrocodone to morphine since it is since it transforms in the liver. It's one of the prodrugs. So they could either change the Prozac so it would not be an inhibitor to his pain relief. They could change it to another SSRI or another antidepressant such as Lexapro or Zoloft, sertraline. And if they wanted to change his medication for pain relief, they could change it to tramadol.
Good choice. Good choice. Tramadol, you don't want to give tramadol with an SSRI. You get serotonin syndrome. But suggesting the switch to citalopram, which is a much cleaner drug, that's a very good choice. Or sertraline. Sertraline, out of all the SSRIs, besides escitalopram and citalopram, is probably the weakest 2D6 inhibitor. So that's actually a really good idea. So very good. Well done. Well done. Okay, case study number 4. Sound off, gang.
So the drug interaction was that St. John's wort is a CYP3A4 inhibitor. And so it starts to break down cyclosporine, which lowers its blood levels.
It's not an inhibitor, it's an inducer.
Cool. It's an inducer.
It's an inducer. It's a potent inducer, in fact, of 3A4. Go ahead.
Oh. Okay. And then let me fix that on my paper. So if it's an inducer, then is there still a risk for cyclosporine toxicity?
Well, he's experiencing tissue rejection, so the cyclosporin is not working because it's being degraded. Because the 3A4 is induced, and the induced 3A4 is chewing up all the cyclosporin. So that's why his transplant is being rejected.
So then, to fix that, he would need to stop taking the St. John's wort. Okay.
Many of you seen St. John's wort in stores? It's on the shelf in a lot of pharmacies. St. John's wort, it's a rather pretty flower, actually. It's made as a tea. And actually, as natural products go, there's quite a bit of evidence that St. John's wort is pretty effective for moderate to mild depression. It's a very good mood stabilizer. The issue is that it has a lot of drug-drug interactions. So if patients are taking that, you really need to know about it because it induces a lot of cytochrome P450s. And as I was telling Clara and Sydney, these case studies are not made up. These are real live case studies where people miss drug-drug interactions. So they can have some pretty dire consequences. And in this case, you have an herbal remedy causing the drug-drug interaction. So it's really important you ask patients about herbal remedies besides the medications they're on. That's kind of the lesson from that case study. Okay, good job, guys. All right, case study 5. Go ahead and sound off, gang.
So we had case study 5, and we basically said that phenytoin was an inducer of 3A4. Yeah, 3A4. So that means that it would lower the blood levels of quetiapine, which makes treatment failure, and so they start having anti-schizophrenic symptoms.
Bullseye. Bullseye. Phenytoin actually will increase the clearance of quetiapine 5-fold. That's how much of an inducer of 3A4 it is. It's potent, absolutely potent. Good job, guys. Okay, case study number 6. I think, Emily, is that you? And your
Yes.
sidekick, whoever your sidekick was. Go ahead.
So we said when the girl is prescribed carbamazepine, she should have been given precaution that carbamazepine therapy may decrease the effectiveness of oral contraceptives. And we said carbamazepine is an inhibitor of C1A2, and then the oral contraceptive is an inducer of CYP3A4, which can increase estrogen. And then we said that instead of taking an oral contraceptive, she could have like an IUD or another form of contraception.
Good choice. Good choice. Copper IUDs don't interact with any drugs at all, and they're very effective. So very good choice. Yeah. Great. Okay, grapefruit juice, case study 7.
So the grapefruit juice, it's an inhibitor of CYP3A4, and the patient was taking carbamazepine, which is also an inducer for CYP3A4. And because he took a large amount of grapefruit juice, it caused a carbamazepine toxicity.
Bullseye. Bullseye. Very good. Very good. And there's a very good chance he never told the healthcare provider about all the grapefruit juice he drank. Because it's not a drug, it's a food. So again, a good medical history is worth its weight in gold. All right, case study number 8. Who's up?
Okay, we said that erythromycin was a CYP3A4 inhibitor, meaning that it cannot break down carbamazepine, which is a CYP3A4 substrate, which leads to toxic levels of carbamazepine in the blood. So the symptoms of toxicity occurred.
Yep. All those symptoms listed there are symptoms of carbamazepine toxicity. Ataxia, slurred speech, jerking limbs, so on and so forth. All right, last one, case study 10. Let's see, I think that's Haley and I forget who else. Go ahead, who's ever gonna.
So we said that phenytoin was an inducer, a CYP3A4 inducer, and which took care of the seizures. And then once they added the ifosfamide, which is an anti-cancer drug or a prodrug, the phenytoin acted as like a booster, or it increased the activity of the metabolite and resulted in successful chemotherapy because it boosted the ifosfamide. So
Very good. Very good. Yeah, this particular case study illustrates the strategy called boosting. Sometimes you use a drug that will inhibit a cytochrome P450 that degrades another drug you want to give. So now this other drug you want to give has a longer half-life and builds up in concentration and is much more effective. Paxlovid, the new COVID-19 drug made by Pfizer, contains ritonavir, and ritonavir is a booster for the other antiviral medication in that particular concoction. And this is an example essentially of a boosted combination. The ritonavir inhibits the enzyme that degrades the nirmatrelvir, that's, I can never say that properly. near matrovir. And near matrovir, therefore, has a longer half-life, builds up in higher concentration, and inhibits SARS-CoV-2 much better because of this combination with ritonavir and nirmatrelvir. The other place you use this is with HIV medicines. You put in ritonavir, which has minimal activity against HIV, but it inhibits the enzymes that metabolize these other HIV medicines. So you get really good activity against HIV using this strategy. In this case, you use an inducer that induces the production of the metabolite that's active. So that boosts the effect of the anti-cancer drug. This is also used in cancer therapies as well. All right, are there any questions about biotransformation, drug-drug interactions, any or all of that before we go on to our next thing? No? All right, let's talk a bit about some of the neurological drugs you're learning about. We'll start with the antipsychotics. This is a complicated group of drugs. And when I went over the ATI one, I said, I think I should give them a bit more on antipsychotics. So your antipsychotics in general are going to tamp down dopamine neurotransmission. That's pretty much how all antipsychotics work. For the second generation antipsychotics, that's not the only thing they do, but all of them address in some way dopamine neurotransmission. So for years, people have discovered that increased dopamine activity in the brain tends to cause schizophrenic-like symptoms. And if you somehow artificially increase dopamine neurotransmission in the brain, you get psychotic type symptoms. And agents that decrease dopamine neurotransmission tend to quell the positive symptoms of schizophrenia. So that is essentially how your first generation antipsychotics work. All of them decrease dopamine neurotransmission in the brain. Your second generation antipsychotics have additional properties, and that has to do with serotonin signaling. So there are two serotonin receptors, serotonin receptor 2A and 1A. Some of them are antagonists at serotonin 2A receptor, others are agonists at the 1A receptor. Serotonin signaling seems to mediate dopamine signaling in other pathways of the brain. And if this mediates some of the side effects that you see with the first generation antipsychotics, also it tends to improve some of the symptoms of psychosis as well, not just positive, but also negative symptoms as well. So this is what all antipsychotics have in common. They all reduce dopamine neurotransmission. The big receptor that they antagonize is the D2 receptor, the dopamine D2 receptor. So these drugs bind to this receptor and they antagonize it. So they are D2 antagonists. D2 antagonists. Now, there is a second generation antipsychotic called aripiprazole. It goes by the trade name Abilify. There's also a close cousin of aripiprazole called brexpiprazole. And then some of the newer second generation antipsychotics like lurasidone, and then some of the really new ones like ones that came out last year. These are partial agonists of the dopamine D2 receptor. So they bind the D2 receptor and they activate it a little bit. So because they get in the way of dopamine, you're only going to get a little bit of dopamine activation from the D2 receptor that downregulates dopamine neurotransmission, but it doesn't shut it off. Now there's 4 different dopamine pathways in the brain. So in the midbrain, you have the substantia nigra, and it extends neurons into the basal ganglia. So this is responsible for voluntary motion. So the substantia nigra consists of dopaminergic neurons. They project up to the basal ganglia. Then you have so this is a so-called nigrostriatal pathway, the nigrostriatal pathway. This pathway here, where you have dopaminergic neurons in the hypothalamus that then send dopamine into the pituitary, this inhibits the production of the hormone prolactin. This is called the tuberoinfundibular pathway. That's a second dopaminergic pathway in the brain. The third is the mesocortical pathway. This one essentially begins with the ventral tegmental area. And the ventral tegmental area then is going to extend into the forebrain like this. That is the mesocortical pathway. Then you have the mesolimbic pathway, which also starts at the VTA and then extends down here to the cingulate gyrus. This one, the mesolimbic pathway, is involved in the reward circuitry, If you downregulate dopamine neurotransmission, you're going to downregulate it in all of these pathways. That's why drug companies have sought to make drugs that are partial agonists, so you don't shut it down completely, because if you shut down dopamine neurotransmission completely in the nigrostriatal pathway, that's going to cause the symptoms of Parkinson's disease. And in fact, Parkinsonism, otherwise known as extrapyramidal symptoms, EPS, they are a major side effect of first-generation antipsychotics. So we talked about the dopamine hypothesis of schizophrenia. This essentially comes from experiments that show that if you inhibit dopaminergic transmission through the D2 receptor, that tends to quell psychotic symptoms. However, this hypothesis does not explain why you can get schizophrenic type symptoms using drugs essentially that will activate the serotonin pathway. Also, if you illicitly activate the D2 receptor, you can get these positive symptoms of schizophrenia, delusions, hallucinations, and the racing thoughts. So psychosis is caused by dopamine promoting drugs like L-Dopa, amphetamines, cocaine, things like that. These cause a transient but definite set of positive symptoms of schizophrenia. Limitations of this, of course, is that they don't explain some of the negative symptoms, the flat effect, the alogia, so on and so forth, the word salad. And also you can get schizophrenia essentially in patients that use drugs like LSD. LSD is a serotonergic promoting drug. It's not a drug that promotes dopaminergic pathways. So while this hypothesis is useful, it's not the whole thing. So your D2 antagonist will block all 4 of these dopamine pathways. Other drugs will also block the histamine pathway, M1, which is a muscarinic receptor, and then alpha-1 receptors too. If you block alpha-1 receptors, it's going to cause hypotension. If you block the M1 receptor, you're going to have anticholinergic effects. If you block the H1 receptor, you're going to have sedation. So these are this explains some of the side effects of some of these drugs. So first generation antipsychotics, that's what FGA means. They're called typical antipsychotics. They're also called neuroleptics. So if you hear that term neuroleptics, those are first generation antipsychotics. Second generation antipsychotics are either called atypical antipsychotics. They also get called serotonin dopamine antagonists or something like that. But atypical is far more common. So as we said before, the second generations, they bind to the D2 receptor, but they don't stay bound to it very tightly. So while they downregulate D2 receptors, they don't downregulate them nearly as robustly as the first generation antipsychotics. They also antagonize certain serotonin receptors and then they activate others. So clozapine was the first second generation antipsychotic. It has a lower affinity for the D2 receptor than haloperidol, which is probably the most widely used first generation antipsychotic. But it has a good affinity essentially for this 2A receptor, H5-HT2A, that's a serotonin receptor. And clozapine, out of the second generation antipsychotics, is definitely the most powerful. It's the one you turn to when everything else fails. Unfortunately, it has some pretty profound side effects, potentially. So we now have the 5-HT2A-D2 theory of schizophrenia. Namely, that the 5-HT2A receptor, when it is downregulated, increases dopaminergic transmission in the nigrostriatal pathway, and also increases dopamine release in the prefrontal cortex. This prevents the shutting down of the prefrontal cortex that you see with first generation antipsychotics, which tended to turn people into zombies. There are some limitations to this theory, but as theories goes, it's probably one of the best ones we have, and I'll just leave you to read this and make your own conclusions. All right, so as we said, the first generation antipsychotics, they bind very tightly to the D2 receptor, whereas the second generation ones, they bind, they get off, they bind, they get off, they bind, they get off, they bind, they get off. These studies essentially come from functional MRIs that can tell you essentially how much time the drug is spending on the D2 receptor, very detailed studies. Here's one of these studies essentially here from the American Journal of Psychiatry, if you're interested. And this simply illustrates that using a picture. So some of your second generation antipsychotics are 5-HT1A agonists. So these three, quetiapine, trade name Seroquel, ziprasidone, trade name Geodon, and clozapine are examples of 5-HT1A agonists. This increases dopamine release in the prefrontal cortex and reduces glutaminergic neurotransmission. Glutaminergic neurotransmission has been linked to some of the effects in schizophrenia. And there are other effects on intracellular signaling that are also noted as well. So when it comes to D2 receptor occupancy, you have a high risk for Parkinsonism if the receptor, the D2 receptor is occupied over 78% of the time. Below 75%, you get good antipsychotic efficacy without Parkinsonism. That's why the second generation antipsychotics do a better job without causing the extrapyramidal symptoms that you see with the first generation antipsychotics. And there's just a summary of all that I talked about already. All right, I'm going to quit there for today since it's 8:30. We will hit the neurological drugs. I'll just do some cleanup on the neurological drugs. hopefully by then you will have mostly gotten through the ATI section for, but have you guys given that a whirl? How's that going? Just give me an idea, or Caitlin, are you done with it? Are you almost done with it?
I did the intro module, but I haven't started the neurological one yet, or whatever. I did the first
Okay.
one.
Okay.
I
So
didn't
that's
do the
good.
test yet. Are we supposed to do all the tests on the end of the modules?
Yeah, because that'll give me a record that'll tell me how well you're understanding stuff.
Okay.
Becca, you gave it a shot? Did you get through the neurological stuff yet, or have you started it? Oh, I can't hear you, sweetheart. Is your microphone working?
Working now?
Oh, yeah, now it's working.
Yeah, the module I liked it. I just didn't take the lesson yet, but
Oh, okay.
I like the setup.
Okay. All right, good. So give that a whirl. I did a practice quiz on the neurologics for you to take, just to be able to tell me how well you understood stuff. And that it's a practice test. It's not graded. Don't stress out about it. Don't break out in a cold sweat. It's practice, okay? Practice.
Also, there's the ATI farm book on the ATI online. I checked. It should be enabled for them. It's in the RN
Yeah,
ebook library.
yeah.
So
That's the
if you
one
guys
with the
need
orange
any,
cover
yeah,
normally.
if you need
Yeah.
anything, yeah, it's online too in the ATI.
Yeah,
So if they
that
need
is a
anything,
very, very good resource. So
Yep,
I
it is.
highly recommend that. So, okay, so we'll pick this up then on Monday, hopefully finish up the neuro stuff and then go on to the next set of stuff, okay? All right, I will hang out if any of you have any questions. Otherwise, I bid you a fond good night and stay warm, all right? And please, if you drive, be careful.